So today what we're going to look at is we're going to look at Chapter 17, Therapy by David Myers, 8th edition AP Psychology textbook. So when we look at therapy, remember this is just an outline of what we're actually going to cover in therapy. So you need to know the different schools of thought in psychology in order for you to figure out the therapies, and then make sure you know the abnormal stuff so that you can figure out which therapy would be best for someone. So when we look at the history of the insane, our abnormal population, it's not been very good. People have been tied up, they've been thrown on ice. You remember we went over this in chapter 16. So people have been fairly abused. Until the hospital system has actually come in, we did not treat people very humanely. And so Dorothea Dix and Pinel, they actually created a very humane way to treat those that were abnormal. And so psychotherapy involves an emotionally charged, confining interaction between a trained therapist and a mental patient. A trained therapist means somebody who's actually went to school for therapy and is licensed. Biomedical therapy is when a trained psychiatrist uses drugs or other procedures that act on the patient's nervous system, curing this person of any psychological disorders that they have. You can't have an eclectic approach. An eclectic approach means that you use a psychotherapy and a biomedical therapy. If the AP exam is asking you to come up with a therapy for someone, you should probably go ahead and give two therapies. You should probably give a psychotherapy and, if need be, give a biomedical therapy. But you should never just alone give a biomedical therapy because biomedical therapy might cure, but it also might cause somebody to become dependent on the actual drug. So when we look at the psychological therapies, we look at the psychoanalytical by Freud, we look at the humanistic, so we'll look at Carl Rogers and Maslow's, we'll look at behavioral therapy, and we'll look at cognitive therapy. So when we look at the psychoanalysis, remember we look back at Freud, and Freud tried to get at the unconscious, the repressed thoughts in his patients. So one of the big things that the psychotherapists try and do is they try and get at your repressed feelings, and they try and figure out what is the conflict between the id, the ego, and the superego. And when they figure out what the conflict is, they're going to be able to actually reduce your anxiety. Normally when you look at psychoanalysis, they look back at your childhood and they try and figure out what conflict rests there. Now Freud, he did use hypnosis, but as I said before, he really does get unhappy with it. And because he becomes unhappy with it, he starts to do free association. And free association is just when someone talks off the top of their head, and then he writes down like symbolism within the talking and tries to figure out what your issues is. If everything's about women, then obviously you have an issue probably with your mother if you're a psychoanalysis. So the patient lies on the couch and they talk about whatever they feel like. When free association is actually happening, sometimes a patient does edit their thoughts, and they're editing their thoughts because they're trying to resist the way that they feel, or they're trying to resist their emotions being expressed out loud. And this resistance is actually pretty important in psychoanalysis because it causes a conflict-driven anxiety. Eventually, the patient will open up to the psychoanalysis and reveal their innermost private thoughts. It could be very positive or negative feelings that develop towards the therapist, and we call this transference. So sometimes during psychoanalysis, a patient actually becomes not necessarily romantically in love or anything like that with their therapist, but they feel that this therapist is something that they need in order for them to keep going. So it could be positive or it could be very negative feelings, so transference. Psychoanalysis, there's some issues with it always. There's always criticism. It's real hard to refute that it works or it doesn't work, and it also is very long and it's very expensive. You're normally going once a week, if not maybe twice a week, to a psychoanalysis therapist. Now, in their, what they try and do in these psychoanalysis sessions is they do a face-to-face setting, and they're trying to understand the symptoms and the themes across your life. And so if all the themes in your life are conflicts with, your mom, then the therapist is going to try and figure out what relationship you actually have with your mom and how you can maybe fix that relationship. So interpersonal psychotherapy is just a variation of the psychodynamic therapy. It's pretty effective in treating people who actually experience depression. And what it does is it focuses on symptom relief for the here and now and not some overall personality change. So it looks at what's causing the depression at the moment and not necessarily like, do you have a depressive personality type? Now, humanists are also in humanistic, are in our therapy. So, humanists, they try and boost your self-esteem, and they want you to feel good about who you are. And because if you feel good about who you are, then your whole life's going to be better. So, there's self-awareness and self-acceptance here. So, Rogers is the guy who develops that person-centered therapy, and he tries to get people to listen to their patient and accept them in a non-judgmental way. And so by not judging your patient and by not telling them that they're a disgusting human being for having those thoughts, by not doing that, you actually build up someone's self-esteem. And think about it, a lot of your teachers actually use this. So when you're talking about why you couldn't do something, if they're in a non-judgmental way and they, are listening to you, then they're trying to build your self-esteem. And maybe you'll start completing your work, right? Active listening is another kind of form or another form of therapy for our humanistic therapists. And this one, what a therapist does is they echo back and they repeat what you've said. And why they're doing it is because they want you to clarify your thoughts. Sometimes people just talk and they really haven't thought out what they're actually going to say. You're jumping before your thoughts are there. And so in active listening, the therapist repeats, it's a parrot talk of what the patient has just said. Now in behavior therapy, what we look at is this is behavioral learning principles applied to trying to eliminate some sort of unwanted behavior. So what they might do is they could treat like phobias, they could treat sexual disorders. And so what they try and do is they don't just look at the surface, they try and look pretty they want to look at maybe like the biology of the actual issue. So they might run tests, they might figure out what's kind of going on. They're not going to look at like inner causes, like why you don't want to go up in an elevator is because your little brother threw you off the second floor of your house or something like that. They're not looking at it. They just want to look at the science of learning and how you've learned to be scared of something. So like biology kind of stuff. So they look at classical conditioning. And encounter conditioning is a procedure that conditions new responses to stimuli that trigger unwanted behavior. So encounter conditioning, you can do these two things. You can do exposure therapy or aversive conditioning. Exposure therapy is when you immerse the patient in what actually makes them afraid. So if somebody is afraid of heights, you would actually maybe get them up in an elevator, a glass elevator, all the way up to the 100th floor. And through repeated exposure, the anxiety is actually going to lessen because you just become accustomed to the height or to whatever it is. So I don't like snakes, and I know that you guys think certain movies are funny, but throwing someone in a pit of snakes could potentially be dangerous, not because the snakes are poisonous or anything like that, but just because it can cause extreme anxiety in patients, particularly patients who have phobia, and it might potentially cause a heart attack. So exposure therapy, though, can do it like in the virtual world. And so what they do is they might give you glasses, like 3D glasses that stimulate an environment. So it might simulate like riding on a plane. And so this way you're controlling the situation and you're monitoring your patient, and so but you're exposing them to something that they're really afraid of, and as time goes on they'll reduce their anxiety when they actually have to do this stuff. So systematic desensitization is another one of our exposure therapies that's done, and this is where you gradually bring something closer to someone that's going to reduce their anxiety, and it's normally used in phobias. Systematic desensitization has been used in OCD patients, and so in exposure therapy, what you would do is you see a little girl, she's scared of spiders, so they show her a picture of a spider, and then they get her closer to the picture of the spider. And then this therapist, the behavior therapist, brings in a toy spider, so a little rubber spider, and she's wary of it, and then they pull it a little bit closer to her. Then they bring in a dead spider, and so the first is a little bit further away, and then it gets a little bit closer to her. Then they bring in the live spider, and they've kind of desensitized her at this point to the sight of spiders, like she's not running out in the room screaming. And then she actually holds the spider. So this would be a pretty good way of treating phobias. So for OCD patients, like the people who have the germ phobia, what they do is they make them touch things like with germs, like touch a toilet seat, And what they're trying to do is get them to gradually change their behavior pattern so that they don't have the anxiety that these phobias are causing. So aversive conditioning is the type of counter conditioning that associates an unpleasant state with an unwanted behavior. So for people who drink a lot, or people who just drink, when you look at this drug, so it's the unconditioned stimulus, and then the unconditioned response is nausea. So you get sick. And so what you do is you can take the conditioned stimulus, alcohol, and now the unconditioned stimulus would be a drug. So you put a little nausea pill in someone's drug. And then what's going to end up happening is the unconditioned response of nausea is going to start. Now every time this person, the conditioned stimulus, drink, the conditioned response is, at this point, nausea, because now they've learned to associate drink with nausea. And so this works temporary for people who have an addiction to alcohol, but it's not necessarily going to be a lifelong solution to a problem. There needs to be something more to it. So operant conditioning is like when you do behavior modification. So a lot of therapists, they try and do like rewards charts and stuff like that, and teachers are pretty good about this one. Whenever somebody has done something right, they get like a gold star, or they get a pizza or something like that. And then undesired behaviors are either unrewarded or punished. And so maybe your parents have like a rewards chart or a chore chart, and every time you do your chores for the end of the week, you get your allowance if you still get one. A number of withdrawn, uncommunicative 3-year-old autistic children have actually been successfully trained by giving them and withdrawing reinforcements for desired and undesirable behavior. So this operant conditioning has been used with our special needs population, and our special needs population has shown growth with it. Token economy is also another one of our therapies that you can use, and this is just when like you do something right, you get a privilege or a treat. And this was like that old treasure box when you were in elementary school. At the end of the week, all the kids who, they stayed on the green card, or they got all the, their work done and completed on time, that at the end of the week, that kid got to go in the treasure box and pull out some special treat and take it home with them. In cognitive therapy, this is trying to teach people to think differently. So it teaches people adaptive ways of thinking and acting based on assumptions that thoughts intervene between events and our emotional reactions. So if you lose your job, there's a couple ways you could react to this. So internal belief, I'm worthless, I'm hopeless, and that could set into depression. Now, if you have this internal belief, like your boss is a jerk and you deserve something better, then you have no depression. So in cognitive therapy, they find that this works pretty well for people who are depressed, and cognitive behavior therapy as well. So you can combine cognitive and behavior therapy and try and change the way somebody thinks and then the way they behave. And so that would be the cognitive behavior therapy. So cognitive therapy for depression, Beck suggests that depressed people or depressed patients believe that they can never be happy, and because their thinking is their issue, then that's what you need to actually cure. And so they associate minor failings like failing a test is a major cause for their depression. Like they think that these little things, these little bumps in the road, are exactly why they're never going to be happy. So Beck believes that cognitions such as I can never be happy need to change in order for depressed patients to actually recover. And so what they would do for cognitive therapy for depression is they try and train the depressed patient to record positive events each day. So try and get them to start thinking about, is something positive happening during the day, and marking it down like in a journal. And they relate how these things actually contribute to events. And so they would compare other depressed patients. The treated patients showed lower depression scores. So the patients who were actually recording every single day, they actually started noticing that they weren't as depressed as the patients who weren't in the treatment group. So stress inoculation training, and this just trains people to restructure the way they think about stressful events. So where you breathe before the test, or you say, relax, the exam may be hard, but it will be hard for everyone else too. I studied harder than most people. Besides, I don't need a perfect grade to score a good grade in this class. So this is kind of just trying to get your body and your brain to adjust, to restructure how it thinks in stressful situations. And we know that people that deal with stressful situations better typically are happier people, and they roll with the punches in life. And so I'm going to pause here, and then we're going to move to the actual part 2 for therapy.